Hi, my name is Jessica Merchant, and I'm here today to talk to you about Health Information Exchange. Let me begin by explaining EHR, or Electronic Health Records. These are essentially an electronic form of the patient's chart that allows for a safe and effective but user-friendly exchange of information between collaborative team members as well as the patient. By adopting electronic health records, organizations can increase quality of care, lower costs, and increase patient safety. Once EHR is established, Health Information Exchange, or HIE, can be onboarded, which is essentially just an extension of electronic health records, but expands the exchange of health information for patients across organizations within a region with the ultimate goal of nationwide sharing. Once onboarded, HIE allows information sharing from all facilities involved throughout the patient's life. Federal legislation involvement with the adoption of HIE included the HITECH Act of 2009, which provided monetary incentive for providers who adopted EHR and proved its meaningful use. This was in hopes that all healthcare settings in the U.S. would adopt EHR. The incentives lessened for late adopters, and eventually practices were penalized and reimbursement rates for Medicare and Medicaid were lowered. The goal was for 90% compliance by 2019. Regional Extension Centers, or RECs, were also developed and made available throughout the U.S. to aid providers and better understand the adoption process as well as its meaningful use components. Some adoption barriers included privacy and security concerns, usability, disruption of workflow, competition between EHR vendors, which could lead to blocked information sharing, and cost, because initial incentives provided did not create a sustainable monetary support of EHR, which requires frequent updates, interoperability improvements, and education for new staff. In 2010, the Office of the National Coordinator assigned states the task of developing their own health information exchange, and each state received funding for this task. North Carolina developed North Carolina Health Connects, and according to the Department of Health and Human Services of North Carolina, all hospitals providing Medicaid services who have electronic health records were required to connect to North Carolina Health Connects by June 1st of this year. All other providers of Medicaid and state-funded services must connect by June 1st of next year, or 2019. A barrier to meeting these deadlines is the length of time it takes to implement EHR, which can take up to 18 months to be fully functional within an organization. And EHR is required for onboarding the Health Information Exchange. Two recommendations I have to advance implementation for HIE in North Carolina address the barriers of cost and competition. Challenges of independent small practices is the cost of EHR. If the state provided grants to some small practices that were attempting to become connected but had financial difficulties, it would aid more independent practices to become connected. Also, competitive vendors pose a block in data sharing and can increase cost, and this can increase cost as well. By mandating a statewide vendor and making an agreement that the vendor would lower their startup costs for practices in exchange for guaranteed statewide use would be beneficial to practices because it would offer EHR for a lower cost, but also decrease the block in information exchange between competing vendors because there would only be one vendor for the entire state. Electronic health records have already created a safer and more efficient Electronic health records have already created safer and more efficient healthcare for patients. As more advances are made and more organizations become connected to health information exchange, we can only plan on seeing greater patient satisfaction and outcomes.